All right, I think we'll get started. Good morning, everyone. I have the pleasure of introducing Dr. Joshua Buckler for today's Grand Rounds. Josh did his undergrad at med school at the University of Michigan. He then did a general surgery residency at the University of Northwestern, and then went back to Michigan and did internal medicine, and then out to Seattle at the University of Washington, where he did his cardiovascular fellowship. He was in practice for 9 years before coming to join our group, and he's been a great addition to our group, and he's joined us out in Laconia as well. We're happy to have him there. And today he's going to talk to us about AFib. Josh?
Thanks, Mike. Is this coming through okay? Good. All right. So thank you guys for having me here, and I am truly honored to be at this group. I think the group has set out some very high bars to try to achieve, and being up here is somewhat intimidating, knowing what everybody else has achieved so far. But I'm going to present to you guys really what I worked on in Seattle, and hoping that we can eventually bring it here. I have nothing to disclose. So the CME objectives we have are to recall the importance of risk factor screening for AFib, discuss alternative therapies that patients may ask about, and really talk about the need for integrated practice units. That's the formal CME objectives. But my own personal overall goal is I want everybody here to recognize that AFib patients are coming from all directions. You need to understand why AFib is like diabetes more than it is a lot of other cardiovascular diseases. We need to gain some insight into emerging data on risk factors. I want everybody to be receptive to patients with alternative ideas. They're going to come, they're going to ask, and you need to know what they're going to be asking about. I want everybody to walk away today understanding the need to build a multidisciplinary team. And so, like so many other issues in medicine, we think we understand AFib, but really, the fact there's much more to it. And there's not a person in this room who has not seen an AFib patient in the last 7 days. I don't care if you were on vacation last week. Sitting next to you at the poolside bar was somebody with AFib. And this is a problem that isn't going away. So we know from data, multiple sources of data, but this data was out of the Mayo Clinic, looking at how we're going to see the continued increase of the numbers of patients with atrial fibrillation. Solid line includes no increase in incidence, and the dotted line assumes that we're going to see a continued increase in incidence over time. And we know it's a problem of older patients. We know that most of our patients are over the age of 65, but not all. I just sent Dr. Abdulhadi just ablated a patient of mine who was 19 the other day. We're seeing this coming in from all directions, and it's costing us a fortune. Well, what's really interesting about the slide, I like the slide because the graphic was really nice, but this is data from 2006. This is pre-Watchman. This is pre-DOAC. This is pre all the new ablation technologies. And so this number is only going to increase further. And in fact, when compared to non-AFib controls, we see a 73% increase in annual expenditures on atrial fibrillation patients. And again, data that's pre a lot of our more modern technology. So this is going to only increase. And this is an issue of patients who are high utilizers. These patients have a lot of ER visits, a lot of clinic visits. They get admitted a lot. If you are an AFib near a lot of ERs in this area, whether or not you're symptomatic, they get admitted to the hospital. And if you're an 83-year-old patient, you get admitted to the hospital. Next thing you know, you're there for 3 or 4 days. The DRG doesn't cover it, and the hospital may be losing money on that diagnosis. The good news for us is that the projections show that the vast majority of profitability and service line growth is going to be in the EP world. It's going to be much more so than outpatient cath, much more so than even a lot of our inpatient work that we're doing. And this is based on projections on CMS data and reimbursements. And so that gives a little bit of background on the scope, cost, and opportunity for these patients. But let's talk about these patients. So who are we talking about? So let's say we play Mad Libs, right? So Beth, give me an age. Terry, give me a gender. Steve, give me are they new or existing, Steve? All right, so you get the idea real quick. So if these are all binary choices, we're talking about 512 different presentations for atrial fibrillation patients. These are not binary choices, right? So what I talk to my patients about a lot is that one of the most unique things about atrial fibrillation is that every patient's story is different. How they present, what they feel, what they need. And there are very few things in medicine where we actually have such an individualistic approach to each of these patients. And so where do they come from? So let's say the AFib patient goes to the primary care provider, and they send them to the cardiologist, and they send them to the EP, which is kind of our classic route, right? But maybe they go directly to the cardiologist. Maybe they go directly to the EP doc. Maybe they go to the ER because they're symptomatic. Maybe the primary care provider sends them to the ER. ER tries to send them to the cardiologist, or maybe they send them to the EP doc, but they're booked out 3 months and they can't get in to see them, so they actually fall outside the system. Maybe they go to some other specialist. They show up their endocrinologist and they're an AFib, their pulmonologist and they're AFib, and they send them to the ER because they're freaked out. They don't know what to do. Maybe they go to their naturopath because that's all they've known so far. But then we don't have any current ties with the naturopath, so who knows where they go? Or maybe, just maybe, they go to Dr. Google. And if they go to Dr. Google, who knows where they go? Well, a lot of them go to the internet. And it turns out if you go to the internet and look for AFib care in Minneapolis, apparently you go to Metropolitan Heart and Vascular, or maybe you go to the university. You can go see Dr. Melby. Apparently Dr. Melby treats AFib, but nobody else here does. So you get the point. I mean, so our presence on the internet is obviously clearly lacking, which is concerning. This is a problem of an aging population, right? And we have a large aging population in Minnesota. So the number of patients over the age of 65 in this decade are going to be more than past 4 decades combined. By about 2020, we're going to see more patients over the age of 65 than under 18. And the number of adults between 2010 and 2030 is going to continue to double. So we're going to have a lot of patients just based on pure statistics alone that are going to have atrial fibrillation. And what I think is we have data on this. Where do patients live? The darker the purple, the more the dense number of patients over the age of 65. And we see a lot on the lakes. We see a lot of Shakopee in Bloomington. We see a lot of Northeast. So that helps us sort of target care a little bit. So state of affairs. Common disease with increasing incidence. It's costing the system significantly. Presents in a myriad of ways, and every individual is unique. It's a problem that's not going away. So we're talking about AFib, right? Well, actually, it's kind of like diabetes, right? Every one of these I just stated is exactly the same with diabetes. And so AFib is like diabetes. And I can't take credit for this quote. This is a quote that a partner of mine out in the Pacific Northwest had come up with. And what he said was, AFib is like diabetes. It affects everything. Think about how AFib interplays with just evaluations at ER and clinic. It's affected by everything, right? So what drugs we choose, what patients' lifestyle looks like, and nobody wants to deal with it. Maybe EP docs want to deal with it, but I can tell you what, a primary care provider at 4:30 on a Friday doesn't want to deal with it, and they'll just blow it off. Well, the endocrinologists for a long time have understood that if you have a disease process that's expensive and complex, that you need to build a team around it. So the endocrinologists, of which my wife is one of them, have worked to build diabetes programs based off of the idea that you need to have multiple inputs. And so they have links up for pharmacists, and they have direct referrals in for eye exams. They've built this network around themselves, very different than the way we currently handle atrial fibrillation. So, as I said, AFib is like diabetes because it's a common disease with increasing incidence. It's costing the system significantly. It presents not only in a myriad of ways, but every individual is unique, just like diabetes. It is a complex diagnosis that would benefit from an integrated team approach. There's currently little to no coordination of care, unlike there is in diabetes. And there's an underappreciation by primary care and others of significance. So I want to take a few minutes to talk about risk factors. So obesity. People in this country are not getting small. And in fact, not only is obesity increasing, we now have this new category called extreme obesity over a BMI of 40. And that's starting to increase. It's only a matter of time before we have extreme obesity. And we're going to continue to see this. And we know that atrial fibrillation is associated with obesity. And so this is the Hunt study out of Norway, 47,000 patients. And what they did was they looked at increasing BMI and then also healthy versus unhealthy. Unhealthy meant you had diabetes, you had high blood pressure, you had increase in lipids. And what you'll see is there's an increase in incidence of atrial fibrillation, but especially in the highest risk group, you end up with a dramatic jump if you are unhealthy. So being overweight is a big problem, but being unhealthy is a bigger problem. Which brings us to Prash Sanders at the University of Adelaide in Australia, who our group had the opportunity to speak with multiple times, who has been at the forefront of looking into the obesity and AFib link. And there's a couple studies he's published that I want to put out today. The first was ARREST-AF, which they created risk factor management clinics. They would see patients every 3 months around the time of ablation and try to work on risk factor management for blood pressure control, weight management, the management. And what they showed is that for patients who underwent ablation, if you underwent the risk factor management, which is the red line at the top, there was a much higher rate of AFib-free survival than if you didn't undergo risk factor management after ablation. So we're talking about an expensive, invasive procedure that we can benefit the outcomes of just by working on risk factor management. They followed this up with a slightly bigger study looking at almost 400 patients in which they looked at just the weight loss alone. They created a weight loss clinic, and what they were able to do is show that if patients could lose about 10% or more of their weight, which if you're 350 pounds, 10% of that's not a huge amount, and it's probably fairly achievable. They saw a dramatic improvement in AFib-free survival. And so that was quite striking. But what the other interesting part of this was that it turned out that it wasn't just the absolute weight loss, but it also had to do with the weight fluctuation. So patients who were on a steady weight decrease, maybe it was a little bit slower, but it was a steady weight decrease, they also had a higher AFib-free survival. So if weight fluctuation was less than 2%, you did much better than if your weight fluctuation was greater than 5%. We know all the data on yo-yo dieting, but it turns out if you could have sustained weight loss that was fairly stable, you did much better long term. And they took the same cohort and they were able to actually look at utilization. What they showed across the board was there was a significant decrease in utilization. If you underwent risk factor management, less cardioversions, more single AFib ablation procedures, not secondary procedures, less ER visits, less specialist visits across the board. And they actually were able to show a cost savings from this. Sleep apnea. Sleep apnea goes hand in hand with obesity, we know, but as isolated as a risk factor, we know that with sleep apnea, the rate of atrial fibrillation risk increases. What's interesting is that as your sleep apnea gets worse, your risk goes up. But for the most part, only patients who are considered obese over the age of BMI over 25 or higher. And obviously, the patients over 30 BMI, the risk goes up much more. It turns out that's actually very important. So patients, again, undergoing AFib ablation, it turns out that if you undergo AFib ablation and you have sleep apnea, don't treat the sleep apnea, you might as well not have AFib ablation in the first place. And that's these two lines down here. If you have treated sleep apnea and you undergo ablation, you do just as well as if you didn't have sleep apnea in the first place, and that's the script at the top. And so this is for a procedure, again, which is costly, invasive. This is really good data showing that we need to be at the forefront of these risk factors. Alcohol. We know there's been a lot of data over the years about the wellness factor in terms of cardiovascular wellness and alcohol use. But unfortunately for atrial fibrillation, sorry, you're hitting the wrong button. The rate of AFib incidence increases with increased alcohol intake. And so this group out of Japan did a really nice study recently, published last year, which they did a rabbit alcohol model. They didn't actually sit around drinking beer. They infused it with ethanol. But what they showed was when they compared bench alcohol-infused rabbits to sham rabbits, they were able to induce AFib very, very easily in the bench alcohol rabbits and not in sham rabbits. They then had a group of rabbits that were overexpressors of an inactivated JNK kinase, which was they were unable to induce atrial fibrillation in this group. The idea was maybe this is a target that we can use to try to treat atrial fibrillation or prevent AFib. It turns out that this kinase is implicated in a lot of end organ damage for alcohol. So what they postulated is that a bench alcohol drinking caused upregulation of this, which will eventually cause increased calcium leak and atrial arrhythmia. So we're starting to understand there's maybe a molecular source for some of these from these findings. Diabetes is not going away. As you can see, this maps out the same data with the obesity, and it's not going away. And we know that patients with, we know for a long time, that patients with atrial fibrillation, or start with diabetes, have increased risks of atrial fibrillation over time. And it turns out that if you have diabetes, your risk of thromboembolism is higher. We know this will be included in our CHA2 basket score, right? So we know that patients with atrial fibrillation are higher risk for stroke if you have diabetes. What is interesting is that in this paper, they show that it seems to be the insulin-requiring diabetics that were at much higher risk. We don't currently differentiate that in our CHA2 basket score, but maybe we should. Endurance athletics. So my wife's a big runner. And none of us have ever done ultra marathons, but she's a runner, I'm a sitter. Both very good at what we do. And to her credit, what the good news is, it turns out that there's a meta-analysis done showing that as you increase intensity of exercise, and most of this is looking at things like endurance athletics, long-distance runs, long-distance cycling. When women, the risk goes down, but men, for some unclear reason, the risk of atrial fibrillation starts to climb. But you're supposed to be healthy if you're, right? Well, the idea is that there's some sort of substrate underlying this that's even gender specific as this dryness, but we just don't quite understand yet. So this is by no means an exhaustive review of all of this better data. In fact, we could spend an entire day symposium on talking about nothing but the risk better data for atrial fibrillation. But it's important to recognize that this data is there, it's emerging, and there's continued data coming out on these topics. And so we've got a growing body of evidence that obesity and the management of can have effects on AFib. Sleep apnea is not going away to be addressed. Alcohol is a related risk factor and now has a molecular cause. And maybe this will provide for a therapeutic target down the road. Diabetes, like obesity and sleep apnea, is a clear independent risk factor which shares common treatment strategies. And endurance athletics places what we thought was a healthy group into a higher risk category. And thankfully, we're starting to see this all filter down into the guidelines. So this is the European guidelines in 2016, and they're starting to get it. They're starting to say, look, we need to start treating these risk factors and looking at these as part of the AFib management. In fact, they actually proposed the idea of really multidisciplinary teams around this. We're finally starting to see it in our guidelines as well. Anyone who read the updated guidelines for 2019, this is the very, very last page, the very, very bottom. They said, oh, by the way, we should probably start thinking about obesity. But you know, it's a start. It's getting us going in the right direction. And so far we've talked about recognizing how AFib patients enter the healthcare system. They're coming from every direction. We talked a little bit about why AFib is like diabetes. And we talked about emerging risk factor data that's out there. So I want to talk a little bit about alternative therapy ideas, and then I want to talk about the ability team. So I want everyone to take these breaths. Breathe out through your mouth. So alternative and complementary therapies your patients might ask about, and you should probably listen. Acupuncture. So this is a small trial in which they used acupuncture at 3 meridians, one on the right forearm, one on the left forearm, one on the back, which are felt to affect cardiac excitability and sympathetic nervous system. And what they did was they looked at these patients post-cardioversion compared to patients who were on amiodarone. It turns out that with the use of acupuncture, they were able to actually show that they did just as well with AFib-free survival post-cardioversion as patients on amiodarone, and statistically significantly better than patients who underwent sham acupuncture, which is acupuncture about 2 centimeters away from the meridian versus no treatment at all. So this by no means a randomized controlled trial, but it's out there, and it's something that patients are looking at. Yoga. So this will look at 3 months of monitoring patients pre-yoga and then 3 months of yoga. What they're able to show is that they show reduction in overall symptoms, both from symptomatic AFib episodes as well as symptomatic non-AFib episodes, essentially where patients think they have AFib, they think they have palpitations, but there wasn't anything on the monitor. Herbal medicines. Admittedly, I know relatively little about the actual ins and outs of all these medications, but patients come, they're either on these or they want to know about them or they're looking for alternative therapies. In fact, some of these, in fact, this Chinese one here, that I'm not going to pretend to pronounce, actually was compared to Pathmone in a small trial and showed similar efficacy. But these are compounds that are widely available. They're certainly not regulated, but they have vasoactive compounds or cardiac active compounds in them that probably warrant further investigation. And there's other complementary therapies out there, right? So biofeedback, breathing techniques, meditation, and there's a lot of work being done to look at these items. And thankfully here we have the opportunity to work closely with the St. George Institute, which is a blessing for us. And in Seattle, Western University is the largest naturopathic school in the country, and we work very closely with them. And so, you know, this is an opportunity for us to say, wait a minute, you know, we know our stuff, but maybe we need to bring some other people in that know a bit more about some of our areas and work closely with them. So it's time for us to start looking at changing our perspective on how we manage, how we deal with inflation. Who knows what this is? So it's the first ever, I thought somebody was going to say, a Duke stress test, but it's the first ever picture of a black hole. Why did it take us until 2019 to be able to image a black hole? Well, it turns out we weren't looking at it from the right perspective, right? So M87 is a galaxy that's 55 million light years away. In fact, the black hole inside of it is only 24 microarcseconds across, which is the equivalent of looking at an orange on the blue from Earth. So it's very hard to see. And for a long time, we've been able to look at this optically with the Hubble telescope. You add in the data from the Chandra X-ray Observatory. You can look at the streams of charged particles coming out of it. But it wasn't until we started bringing online multiple telescopes at once to create a much bigger view that we were able to image this. And in fact, when they built the Event Horizon Telescope, it's essentially a collection of 7 telescopes around the planet, and the diameter of the telescope is equal to the furthest distance between any 2 points. And so it's from Spain to the south is the diameter of the telescope. And when they first brought on 4 telescopes back in 2012, they were able to look at this is gas coming actually out of the black hole itself. And then finally, when they were able to bring on all 7 telescopes online, they were able to look at the picture of the black hole that we found. Just to put it in perspective in terms of the sheer volume data. So there's petabytes of data. There's so much data they actually could not transmit electronically. They had to hand carry hard drives full of data to a central location to process it. The data collection was for 10 days in March. And so it gives us the opportunity to say, well, maybe we need to start looking at the way we do atrial fibrillation specifically. And so if you look at really successful programs around this country, the way they manage AFib programs, if you will, is that we have EP docs who are extremely busy, who end up seeing atrial fibrillation patients, whether they're direct referred or self-referred, but they're largely focused around cardioversion, catheter ablation, surgical ablation, and now Watchman and atrial appendage closure. But we know these atrial fibrillation patients aren't always coming through us. They may be coming from every which way. So we need to build a team around this disease process. And so we know that patients are entering the system from many directions. There's always risk factor data. There's rapidly growing treatment options that are out there, and there's a lot of non-traditional therapeutic treatment options. So currently there's no cohesion, there's no collaboration, there's unknown numbers of unrecognized patients, and that we have an opportunity to have a large impact. And so we look at atrial fibrillation care in general. Think about how in the hospital, right? Where does AFib care largely fall on? Well, it falls on primary care a lot of times. ER sees a lot of these patients, hospital medicine, general cardiology. EP docs do a phenomenal job treating patients, but the bulk of these patients don't necessarily make it to EP at the time. And so when we were in Seattle, what we did was we said, where did all these patients go? And it turns out, when you looked at the atrial fibrillation patients in the system, all of the SMG is Swedish Medical Group, all of the patients that had a primary care provider in our enclosed system, only about half of them saw a cardiologist or EP doc. Of the patients that were not inside of our system, only about a third of them saw a cardiologist. So a huge number of patients that were never being seen by cardiology in the first place. Steve Bradley helped me get a little bit of data out of our own data set. And of the patients here, we do a much better job, but still 20% of patients never see a cardiologist within our system. And I was able to pull a little bit of data from RichView, which is somewhat of a trick to get out. But again, we believe there's a large number of patients that are not being seen by cardiology. So there's a huge opportunity here for us to get involved with patients. A really quick side note about the AFib patients that Steve was able to provide me. We continue to see increased ablation volumes, but we have relatively small numbers of patients with aortic ablation. We don't have the number on AFib ablation eligible patients, but the number of patients I would expect this to be higher. And we have a huge opportunity on anticoagulation to intervene on these folks. So overall, there's a lot of opportunity. And so in Seattle, we had the opportunity to actually be included in a white paper that was on building a best-in-class AFib program with a bunch of other organizations. And this paper basically set out a whole bunch of drivers that are going to set the case for why we need to improve AFib care delivery. Patient volumes are increasing. We know that. This is a chronic comorbid disease process. It's costly to treat. value-based care is going to be increasingly important over time. It's difficult to identify, right? A lot of patients show up in the ER with a stroke for the first time, or maybe they're asymptomatic and they get stuck accidentally. There's a variety of treatment options available, and there's a lot of emerging risk factor data. So we set out, we want to reimagine atrial fibrillation care. We want to optimize and standardize and integrate comprehensive care algorithms based on current evidence, all across the board for all areas of input into the system. We also want to work on risk factor data and build a comprehensive care model for new and established patients across all specialties that are involved with atrial fibrillation care. And we want to make sure there's bi-directional communication with the group. And we want to build a world-class center of excellence focused on care, research, and education. But it was important for us to first recognize that atrial fibrillation is not like that. This is not a situation where the AFib patient shows up in the doors of the primary care, they send all the patients into cardiology, we treat them all. AFib care is like this. The AFib patient has multiple points of entry into the system, which is the green square. And there's lots of providers that are involved with these patients. There's both from an identification versus a risk factor treatment versus a management. And it's important to recognize that it's going to have to be a network that we're going to build over time. So our program vision was such. We said we wanted to develop a program which shifts the paradigm away from the current piecemeal state, largely focused on reactionary treatments, to one which incorporates the value of integrative practices and focuses on coordinated, interdisciplinary care. We wanted to develop and deliver new care models to try to use these tools to increase access to state-of-the-art clinical care. And we wanted to be recognized as a regional, national, international thought leader. The reason being that we recognize that if we could start to change the way we looked at atrial fibrillation and look at this as a disease process which requires multidisciplinary care, we could start to affect care from the country and maybe the world. And so we set off with this project. Briefly on integrated practice units for those of you who don't know what this is. So Michael Porter wrote a paper in 2013 called The Strategy That Will Fix Healthcare. It was published in the Harvard Institute. The idea was that with the increasing focus on value-based care and cost containment, that for some of these complex disease processes like diabetes and spine care, two that were most talked about, we need to be able to bring the patient into an environment that was in which we had all the tools needed to treat the process. So a really good example of this was in Virginia Mason in Seattle, where they've been focused on value-based care for a long time. They have a spine, and if you have back pain, I should say back pain, if you have back pain, you call a central, you can be seen typically within 24 hours. When you come in, you get evaluated by a physical therapist and a PM&R doc. And from there, you are then evaluated for whether or not it's a surgical issue or a rehabilitation issue. A lot of times, physical therapy can be started within the same day. And they showed dramatic increase decrease in days of work lost. It showed dramatic improvement in costs. And so this is an example of how bringing a comprehensive team to the table to try to treat the disease process rather than having individual providers try to do this all. So the key was, though, that you had to make sure that you had not only a multidisciplinary team, but you need a quarterback. And you need to basically, ideally, be located in a similar facility. So ideally, patients should have a one-stop shop to go to. And so when we built the program, what we said was, and I think because I had a program coordinator to work with, and we worked hand in hand. There's really three core beliefs we set out with. One was customer service, second was completeness, and third was communication and connection. Customer service was the idea that we're only as good as our weak link. We need to be able to bring these patients in. That means both access of patients, so that if patients need to be seen, it's not 3 weeks to get seen, it's relatively quickly. That the primary care providers saw us as a resource. That we educated not only the patients, but the primary care providers, and that we were a leader in the conversation, so that patients and providers look to us to try to see their patients. We want to make sure the patients got thoroughly evaluated, the risk factors. We want to make sure they got thoroughly treated and knew what all of the treatment options were. And that communication and connections was the linchpin, right? We had to make sure we communicated to the patients. More importantly, even for communicating amongst providers, We want to have a good, active conversation amongst the industry and be at the forefront of new technologies that are coming out. And these were our global goals. We wanted to increase the access. We wanted to address risk factors. We want to standardize care. We want to reduce ER visits and length of stay, increase the use of definitive therapies, including catheter ablation and LA exposure. We want to increase the anticoagulation utilization, particularly NOACs, reduce costs, and improve outcomes and quality of life. We decided not to tackle cancer and world peace, but we figured this is this. And so these are the tools to reach that goal. The first, multidisciplinary team. So we first sat down, brainstormed, said, okay, who is AFib? AFib process was passed, right? So general cardiology, EP, cardiac surgery, primary care, hospital medicine, these are the ones that most commonly see the atrial fibrillation patients. But we recognize that patients are seen also or have a risk factor that cross the path of sleep medicine, pulmonary, endocrine, and the naturopaths. And it's interesting, when I first sat down and postulated the idea of bringing the naturopaths on board, our cardiac surgeons, like, oh, come on, what are you talking about? I said, look, you got to realize that these patients, especially in Seattle, but I think here as well, a lot of patients who never see an allopathic physician. They still have AFib. And if we don't communicate between these groups, we're never going to be able to have a positive impact on patients. And so for standardized care, we started building care pathways. And this was an example of, and I don't expect you to do this, but this is our internal cardiology pathway. The idea was we wanted to standardize care amongst the group, whether it's the ER, the hospital, the cardiologist, to say, this is how we believe that Swedish should treat atrial fibrillation. Now, it wasn't going to be 100%, but we want to be able to stand up and say, we believe this is the right way. This is all evidence-based and guidelines-based. We want to work on communication. So there's a lot of complicated communication pathways that occur. So we need to look at tools to try to make sure that communication was happening. And this is the global structure of the program. We recognize that not every patient was going to be seen in the AFib clinic. We weren't setting out to try to take all the AFib patients away from all the cardiologists. So what we wanted to do was we wanted to be able to build a departmental infrastructure. So we developed care pathways. We wanted to develop epic tools, communication tools, and have the research backbone be available to the entire department. We also wanted to create an AFib clinic, which I'll talk about in a second. And then we had the other two pieces were the education, outreach, and technology innovation. So the AFib clinic was largely built around the ITU model. The idea was we're going to have the general cardiologist along with an EP doc and APPs on both ends, affiliated specialists, depending on who ultimately thought were going to be the most useful, sleep medicine doctors, pharmacists, psychologists. We actually had a psychology program that was interested in linking up with us to try to address some of the patients that were hindered psychologically by this disease process. And then same-day urgent evaluations for cardioversions. I mean, I hate to say this, and Dave Larson out here, who thankfully is a cardioversion many of my patients in the ER, but we'd like to try to keep those folks within cardiology because we have the opportunity to provide same-day care, decrease the burden on the ER, and manage our own patients. And it's important to recognize that we saw this as bidirectional, right? So the idea was to have referring providers send them into the program, or even just the general cardiologist, so the patient got seen. The cardiologist would initiate the workup. The cardiologist would see the patient, deal with the risk factors, get the sleep studies ordered, start working on the weight loss, send the appropriate patient on the electrophysiologist. We also wanted the electrophysiologist to send patients back to us who weren't quite ready for ablation. The idea here is we didn't want the electrophysiologist seeing 85-year-olds with rate control. We wanted them seeing patients who were ablation appropriate, patients, and sort of trying to filter down patients that were to be most appropriate for their care. EP docs are a limited resource. We all know this. We all have waited months for our patients to get seen. And so we want to find a way to try to make this more efficient. And this is our internal leadership structure. We had triad with me, our program coordinator, who was an AP and administrator, steering committee, and everyone was equal on this. It involved all the areas that we thought were most highly touched with atrial fibrillation. And then the group was set out, we had, of course, tasked with developing the program. We wanted to keep monthly data and oversee program modules. And so these are the 6 program modules we set out: access, referral, communication, and coordination, risk factor management, patient education, research, and program education and technology. And this is our short-term goals were we want all patients to be able to be offered employment for 48 hours. Not all of them may be seen in 48 hours, but offered We want to be a resource to the ER primary care. We want to keep as many patients and procedures internally as possible, ensure new active points of the system through whether it be community events or linking up with the naturopathic physicians. And we want to build a risk factor management program. We want to make sure we try to capture long-term goals, which is to capture a majority, if not all, the atrial fibrillation patients, increase anticoagulation utilization, increase the use of definitive therapies, and then demonstrate success in our key goals to decrease costs, improve outcomes, and improve quality of life. So the initial work we worked on was to ensure access. So we created a hotline. We had a pager and we had a phone number for the ER and our primary care providers to call. It's Friday, 4:30. We have a patient in the primary care office with nuance at AFib. You call us, we see that patient Monday morning. That took the burden off the primary care providers. We could give them advice on how to manage it over the weekend, but we just basically were handoff for the providers. And we had to make sure we were closely monitoring. So we set out that we proposed the idea that we have secret shoppers test out the systems to make sure it was working. So, as I showed before, we started working on design to care pathways. So we built pathways for the ER, we built pathways for primary care and for cardiology. We want to leverage the power of Epic. So one of the things I'm stepping into here is to try to help out with Epic to try to make sure that we are utilizing the way that it's designed to. And so we started building templated notes. So we were beginning the initial discussions around smart set, smart rates, so that these things can be shared with the department. We had to work at building the referral pathway. So every group that we were working with was going to have a different referral pathway. For some people, it was just having a phone number that we could call to get patients in quickly. For our sleep medicine colleagues, actually it was they expedited all of our referrals with our AFib patients for sleep studies. They got to go automatically top of the list, and we were actually in the next stages of being able to directly refer to sleep studies for all these patients. We were starting to see some of the patients in clinic. My program coordinator started to work on weight loss in the clinic. She was very passionate about this. And starting to all the emerging data, she thought it was very important, so we started working on that. We wanted to develop patient-facing elements, so group visits, screening community events, and we want to better presence on the website and Google. We want to be able, when patients start looking for help, we want to be there for them. And the education materials, which we want branded, both paper and electronic, and eventually develop an app. The big picture on the horizon, we really want to eventually have a benefactor AFib program. We want to do this in a way that was not done anywhere else in the country. So it be a comprehensive program with support. And we wanted to have it a designated multidisciplinary clinic space. We did not have the data infrastructure at Swedish that MHI does. And we wanted to become the model integrated AFib. We wanted to basically say to people, look, this is the way we think it should be done. And it's interesting, there are programs in the country that are starting to tap into some of the risk factors. So the folks at UPenn and UNC both have some portions of this. They're working on a weight loss, but nobody has done this comprehensively. So in general, what we want to do is shift the paradigm from very piecemeal, reaction to disjointed care of atrial fibrillation, where all the AFib patients, there's no central sort of pathway through, to a future program where it's comprehensive. So at Swedish, we had started all this. By no means had we finished this. I left and I came here, and I'm very grateful for being here. But I left behind this program, and as of January 1st, they had raised $500,000 in support of the program. Turns out there's a lot of patients with atrial fibrillation who really feel passionate about it. If you know anything about what the patient community is like around AFib, there are websites. The website stopafib.org that's very involved. There are patients who really care a lot about this, and so the idea is that we thought there's a lot of resources to try to build a program. Again, unfortunately, I left. Unfortunately, what's happened since that time is because for various reasons, the program coordinator has also left for having to give back that $500,000 in support. So maybe we go. So my question to everybody here is this something we could build here? I truly think that this is the future of the way we'll manage this disease process, and I think it's much more involved than anyone's ever given it credit for in the past. And I think that with the right tools and the right energy around it, we can make it all happen. So what did we learn? So AFib patients are coming from every direction, and a lot of those pathways do not cross through cardiology, so we're missing a lot of patients. AFib's like diabetes. It's a complex disease process. It's costly, and it's going to require some degree of coordinated care. There's a body of evidence for risk factor modification, and that body of evidence is growing rapidly. Patients are going to come in with alternative therapy ideas. If they haven't so far, they will. And the future of AFib care is in comprehensive programs. We're going to have to find a way to try to address this. So that's all I get. Questions? Yeah, or comments, please.
You know, I think, well, of course, as an electrophysiologist for many years, we've recognized this problem for a long time. Part of it has to do with, you know, how we're paid in healthcare as to how a program runs. I think that the future has always been, you know, should we do more disease management rather than react to a disease? I think at our program here we have unique opportunities now, actually with the Beyond 5 and some of the things we're doing there, because now we actually have nurses that can answer the telephone on the weekend. I mean, if you think about it, what happens to a patient who comes into primary care most times in this community, they're sent to the ER. And, you know, the ER is a very expensive place to deliver health care, but it's reimbursed. So should they actually be sent to, you know, maybe, well, how bad do you feel? Maybe just control them and come in electively to our cardioversion program and use that as a portal. Or, as you indicate, you know, atrial fibrillation in the elderly is very common, and the treatment paradigms are very different. So as electrophysiologists, we, you know, if I told you for 20 years we've talked about an AFib clinic, and our clinics are already overwhelmed, right, with long waiting times. So, you know, hanging a banner that says, if you have AFib, come and see us, we don't have any way to accommodate that. We do not. So unless we do it differently, right, that won't happen.
Right. Well, it's a good point. And I think that's been the common reaction when I'm presenting to the people, is that we're already fussing at seeing how could we handle this. And I think that if we plan it forward and utilize general cardiology and care pathways and APPs, the idea is if we are relying on the electrophysiologists to see these patients, you're right. There's no way that this could all happen. But I think we can work on ways to, you know, build this in sequentially. So at the first line is building some care pathways. So the primary care doctors know, you know, what needs to be done. I agree with you that the ER is reimbursed, but as we move forward, treating an AFib patient in the ER is not going to be as valuable as, say, treating a chest pain patient down the road. So I think we're going to have to find a way, and a lot of patients are getting stuck with these bills, you know, for these visits, and I think we're going to have to find a way to be good stewards of the resources going forward as well. So it's going to take some work to try to figure out a way to handle all these patients. Because right, if we put it out there tomorrow, we'll have wait times of 6 months to contain it. And so we're going to have to be very, you know, very methodical in how we watch this.
But I do think, again, I would applaud the efforts, because it's certainly very needed and highly needed. I mean, the way we do it now is very expensive and fragmented. There's no question in our minds at all.
Yeah, I had a quick question, comment about, you know, your experience with the obesity management, which I think is, you know, truly upstream, right? Because it would treat a bunch of things. Any success with bariatric surgery back at Swedish and?
Yeah, so I mean, we actually had worked with bariatric surgeons to those referrals as well. They actually had also put us, just like the sleep medicine docs had put us at the top line trying to get those patients in. You know, we had not had a program running long enough to have downstream outcome data for those folks, but we already recognized that was going to be important that way. They also have a lot of resources around weight management as well, so we talk more about global weight management. The stuff that's posted out of Australia, they actually just did that in their cardiology clinic. They were paying miles, obviously, down there, but they were able to do this purely through a patient education and counseling, And then actually, if it was at least 3% of your weight, they switched you to these little meal sachets, these little reduced calorie, low calorie diet sachets that people find.
Great talk, Josh. As you're talking about this, I'm thinking about the Michael Porter model that I've always struggled with because it creates so many different silos of care delivery, when in actuality the same team that you designed would be effective for coronary disease, for heart failure, for so on and so forth for these chronic conditions. So I wonder if there's an opportunity to think less about it in the disease-specific context, with the exception of developing the algorithms or the pathways, because I think that's a critical component and a huge opportunity. But less and more about developing the interactions and the relationships and the who goes where for I need to address weight management in Shakopee versus weight management in chest or wherever.
No, and that's why. So if I go back to this, the structure of this, that's why this part of it was actually a huge part of the whole program. The AFib clinic itself was a way for us to be able to start doing some of our discussion management counseling ourselves, for a way for us to be able to be a central depot for the patients. So one of the problems we ran into in Swedish was that all the cardiologists were busy, right? And we felt passionate about the AFib patients, and we wanted to make sure that we felt passionate. We wanted to make sure that there was a way for the ER and the primary care to get those patients into ECC. And so that's where we started building our AFib program around, really around access. But you're right. So, I mean, the idea is that we recognized that there was no way that program itself could see our patients. It was really about building the infrastructure for this pathway. So it's all about building the epic referrals, for building the template notes, things like that were going to make it so that the patients got really effective care, whoever saw. And so it's a great point, Dave.
All right, thank you, Dr. Buckler.
Thanks,